Hi, this is Dr. Nick with the ECG Academy, and this week's Chalk Talk is a bit of a challenge because it doesn't happen very often, so I thought this would make a great Chalk Talk. Anyway, this is a patient in the ICU, and they've been in atrial fibrillation for several days. The patient is on intravenous cardizem, and they're getting some beta blockers, and here it is right about midnight. The patient suddenly has this profound bradycardia, but it only lasts for a few seconds. Okay, now, let me explain how this strip is put together. These are 3-second marks, but this gray hashed area is exactly the same as the first part of this strip. It's just kind of showing you what came next. And you can see two profound pauses here. We can count up milliseconds. It measures just about 3.9 seconds here, and this pause is about 1.6 seconds. And then as you can see, there's another pause here of 1.4 seconds, and then suddenly the rate picks up again. And so what would be the reason for this sudden bradycardia? Now remember, when you're thinking of bradycardia, you have to think two different levels and two different mechanisms. You've got a sinus node problem, and you've got an AV node problem. And of course, you have intrinsic and you have extrinsic. Extrinsic would be something like a metabolic problem or hypoxemia or drugs or autonomic influences like a vasovagal attack. And you have to put it all together. So let's take a look. On the left-hand side of the strip, if we look at the Qrs Complexes, the average here is just about maybe a little bit faster than 100 beats per minute, maybe 105. Do we see P waves? Well, there's a big bump here, and that could be a P, but when you look to see if it's consistent, it doesn't look like it. In fact, you have an inverted atrial signal there, and then you have an upright signal, but it's right on top of the Qrs complex. Then you have a little jiggle here and more jiggles there, a little bump there, and all of the atrial events look kind of different. So even though it's kind of regular, my first guess is that it's probably atrial fibrillation, all right? And then you have this pause here, actually 3 pauses, and then the rhythm picks up again and it becomes rapid, and again you have an average rate of maybe 100 beats per minute, but it's much more irregular here. And again, I think you can see a lot of baseline junk here that suggests that it indeed is atrial fibrillation. So you have atrial fibrillation, and then it suddenly becomes very slow, and then it goes right back again. And this change in heart rate gives food for thought. What actually happened physiologically? What was the heart doing? What's the atria doing? What are the ventricles doing? Well, the ventricles aren't doing much. What's the AV node doing? And this is the kind of approach you have to have. So when I showed it to the residents, they were guessing. Oh, Mobitz 2, AV block. Oh, sleep apnea syndrome. All sorts of things came out. Okay, but the key is that the patient is in atrial fibrillation, right? And what determines the heart rate during atrial fibrillation? It's the AV node. The AV node is the gateway to the ventricles. So the AV node determines how fast the heart goes. And so you've got this rate of 100 on this side of the pauses, and you have a rate of about 100 on this side of the pauses. And so when you suddenly see slowing, you have to think, well, could the AV nodes suddenly stop functioning, suddenly become completely blocked to the point where you have, some kind of escape beat here? There's certainly no P wave in front of it or in front of this one. And so is it likely that the AV node just stopped passing signals down to the ventricles? Well, if you had a very wide Qrs complex and maybe had trifascicular conduction system disease, then I might buy that. But what you would expect, at least if that were the case, is that you would continue to see evidence of atrial fibrillation at the point where the AV node blocks. It's almost like you gave the patient adenosine and blocked the AV node, and then you saw, what the atrium was doing underneath. And you've done that in the emergency room, perhaps, and you'll see like flutter waves or fibrillatory waves. I don't see any of that. What is that? I see some electrical noise, but I don't really see any atrial activity. What happened, in fact, here is that somewhere right around here, the AFib stopped. That's right, it just terminated. And what do we say about overdrive suppression of the sinus node, right? When you have this rapid atrial signal, it suppresses the automaticity of the sinus node, then add to that a little bit of calcium blocker in the way of IV cardizem and a little beta blocker, and basically there's no sinus rhythm, not even a single sinus P wave. What you have here is a junctional escape, and in fact, These 3 beats are all junctional escape beats, but right at this moment somewhere, the AFib starts again, and then it picks right back up where it left off before. So the AV node is still conducting the same as it was before, except what you see here is a very, very long sinus pause, or most people over 3 seconds would call it sinus arrest, and this is an example of what we call a post-tachycardia pause, and it's seen in patients with Tachycardia syndrome because their sinus node isn't working right. So they have this atrial tachyarrhythmia, namely atrial fibrillation, but when the AFib stops, the sinus node is nowhere to be found. What makes this unusual is that most of the time when AFib stops, it stops for a while, and eventually you get some sinus P waves that peak out, and you're back in a normal sinus rhythm, at least for a while. In this case, however, the AFib started up again without so much as a single sinus beat, and that's what makes this so unusual. But when you approach this with the physiologic knowledge, you can easily figure this out. And I do talk about post-tachycardia pauses in my section on sinus node dysfunction, and you can find that in the basic level ECG course. Repetition is the key to learning, but I designed these Chalk Talks to keep you thinking and show you stuff you've never seen before, because you're not going to see this in the textbooks, and that's why the Chalk Talks are one of the most valuable parts of ECG Academy. So check out the website and subscribe now so I can help you become an ECG expert.